what I'm presenting today are the preliminary 6 months result. We just finished 12 months data collection about 6 weeks ago, so I will actually start Monday. I've peaked a little bit, not too much, nothing that I can really say yet. But so these are just after the intervention. What are the differences between the two groups? So I'm going to start with going with our theoretical framework, and I haven't checked time. I don't know where I'm at, so you just tell me when I'm going crazy. So let me tell you first what people chose to work on, and these obviously add up to more than 100% because people chose up to 3. So healthy eating actions, the most popular was actually about drinking, which is a major item. As we know, we can consume a lot of calories from sugary drinks. So 50%, just above 50%, chose to always have a low-calorie beverage available instead of sugar soda and or sweet tea. The next most popular healthy action was to identify one unhealthy food or drink and not allow it in the home. And then purchase fresh vegetables and fruits at least once a week and make them easy to see, easy to grab. So we saw significant, and all the changes, luckily, are in the right directions. We had an increase in the fruit and vegetable inventory in the obese intervention participants. And by obese right now, I tease out people with a BMI between 30 and 40. So I have overweight, obese, and morbidly obese. Unhealthy snacks and drinks in the home went down. Food placement went in a good direction. Trying new healthy foods. Meal serving habits. Eating while watching TV was improved, meaning less. And TVs located in the room where meals are eaten. We did not see any difference between the two groups in the healthy snacks and the healthy drinks, which is really not surprising as we didn't target those. It was more of an elimination. Grocery shopping for fruits and vegetables, the frequency did not change. Family meals from non-home sources, restaurants, fast food. Weighing yourself and telling others your weight, which we kind of had an inclination would be a little bit tough. And social support for healthy eating, which we had seen in our pilot study, but in the pilot study we had recruited a second family member, which was incredibly difficult to work with in a study setting. In the physical activity environment, most people chose to post and use a family exercise log to help you and your family keep track of your exercise. Second most popular was keep at least one piece of exercise equipment or aid in a visible location and commit to using it once a week. And then identify and commit to walking to a place in your neighborhood at least once a week. And the coaches helped with this. For each healthy action chosen, they were actually mailing. So if it's the neighborhood, for example, we had maps of the neighborhood where they would sit down and identify places where people could walk to. Or we sent them like those exercise logs that they received a stack of those, and they could make additional copies to actually track exercise. And there's research linking that if you track your exercise, you're more likely to move more. We saw significant change in the exercise equipment in the home. In the placement, we asked questions like, on a whole list of things, do you have this? Including things that you have in the home and things that you might have in the yard, or bicycles and things like that. But also we asked them, are those things easily accessible and easy to see? Because if you have it somewhere in the attic, that's not really useful. So we also saw an improvement in the placement of exercise equipment. There's exercise space in the home or in the yard, so people made space. And incorporating physical activity into daily life. We did not see any significant change in physical activity with another household member, which we also had seen at the pilot study. While in the pilot study, we had actions that were like, I really want to exercise with a family member, and most people chose that, and it didn't work. They couldn't get other people to exercise with them. So we changed the strategy on this, because people felt like failures if they couldn't get somebody else to move with them. We saw no change in having rules for screen time and social support again. Now to the primary outcomes that we're looking for. So we saw a significant reduction in energy change. I also want to point out, I mentioned this earlier, there's humongous underreporting, which is known in the literature, and it's known that women underreport more than men. Non-white women underreport even more than white women. So there's all these, and also people with lower income underreport more. So we have actually an average baseline intake of 1,400 calories. But we saw over time a significantly larger reduction in caloric intake in the intervention group, and a significant reduction when we broke it up by weight status in the obese group, but all are in the right direction. We did not see any change in physical activity, and this is our objective measure. So people, the accelerometers did not pick up on more movement. And I want to say this with caution because we're just starting delving into the qualitative notes from the coaches, and we find that a lot of people report doing physical activity that the accelerometers might not pick up. There is some weightlifting in there, like simple things like just water bottles or cans. There's little things like riding a stationary bicycle. We know they don't pick those up. So we might not have picked up on it. We started looking at the self-report of it, and there's a little bit of an increase. It's not statistically significant, but it's about 10 minutes a week on average in the intervention group. We saw a significantly larger decrease in weight. We actually saw a decrease. We're aiming for weight gain prevention, but we saw a larger decrease. So on average, the intervention group lost about 8 pounds, which actually translates nicely to the amount of energy intake reduction that we have. And interestingly, the largest reduction in weight was in the middle age group from 45 to 54. So as an overview, looking at our theoretical model, we've seen more changes in the food environment, except for the social support. We've seen some changes in the physical activity environment with a little bit in the social behavior. And then we actually have behavior change on healthy eating, and we have weight change in the intervention group. So where do we go from this? First of all, we have a lot more data to analyze, and then we have to publish on this, which we're working on diligently right now. We're working currently on adapting the intervention to young adults. We're actually probably going to start recruitment in the area on Monday. We're focusing on people in their 20s and see what they think and how they live. And we started thinking about this is incredibly difficult because people in their 20s vary widely. When you think about somebody 20, somebody 29. So we're trying to learn how we can reach this group and what would be a meaningful intervention for this group. Do we need some online components? Do we need other, are people open to a coach coming into their home? What do their homes look like? How much control do they have over their home environment and things like that? We also have worked on some proposals to adapt the intervention for families with young children. And then we've always talked, and we're still working on getting funding for this, to take this general model where it works. We're still working on where it works. It seems to be sustainable change for the healthy eating, to take it to scale in Southwest Georgia and linking the patient home to the patient-centered medical home. And then I have acknowledgement for all the people who are doing the hard work on this program. And I don't know if I have time. Yes.
Okay. Good morning. Can everybody hear me okay? Yes. Okay, good, because I don't talk very loud. I'm getting some strange looks, and so let's clear up a couple of things really very quickly. Some of you are looking at me like, dude, what the hell happened to your face? Okay. Let me explain this. For over 8 years, I've had a sterling record. I ride a road bicycle. And within first 8 years, no major crash. The last 30 days, I've had 2 major crashes. The first one only cost $500 because I landed on my shoulder. The second one I don't remember much about, but apparently I landed on my face. And it cost $5,500. So if you're going to have a wreck, shoulder, not your face, trust me. Secondly, I didn't realize there was going to be so many students here, so I promised to bore you to death. However, if you happen to hang in with me, you may find a couple of nuggets that if you're ever asked to do some research, this may kind of be like a Cliff Notes for you, a shortcut to be able to find some very valuable data that otherwise you may not even be able to look for. So I've been asked to take a look, to show you Phoebe's community dashboard. It's relatively new. It's been up for about 6 to 9 months, I guess. It's powered by Healthy Communities Institute out of Berkeley, California, by a bunch of researchers. And I have 135 indicators to show you. I will not go over all of them. First of all, to get there, all you have to do is to go to www.phoebeputney.com. And as you notice, it says right there, we have a continuous ribbon. And you can either go and wait for the icon where it says Building Healthy Communities, or you can shortcut it and just simply go to quick links. I can't find the mouse. Oh, here it is. And go to View Community Assessment Data. There we go. We got it. Had to get through the icon. This is our landing page, and whatever I'm able to do today, you can do as soon as you leave this room if you want to. The landing page, the look and feel of it, the next 2 to 3 weeks is going to change, but the functionality will not. We're just going to kind of massage it a little bit to the look and feel to make it fit a little bit more with what our priorities are from a community benefit standpoint. If you notice, you see this is what's called a mini dashboard, and every time you hit the browser, it will reload, and it will reload different indicators. This happens to be 5 indicators. The default is always Daugherty County. We have 5 counties because that's our primary service area, so there would be Daugherty, Lee, Terrell, Mitchell, and Worth counties. All of them have 135 indicators. So let's just go ahead and also let me show you something on the landing page as well. What in the world? Okay. As you scroll down, you'll see a Disparities Dashboard. So if you really want to go right to the gut of the matter, if you're interested in disparities, you can go directly to the Disparities Dashboard. Not all indicators have a disparity component to it. Quite a few of them do. So let's just click it on and see what we come up with. These are grouped by topic and then by subtopic, for example. So we have insurance. It's done by age, by gender, by ethnicity. Children with insurance. All sorts of age-adjusted death rates for cancer, for diabetes. Infants born, also low birth weight, very low birth weight, teen pregnancy, teen birth rates. But anyway, there's probably about 40 or 50 indicators that also have disparities attached to them that you can quickly go to. I want to take you right to the dashboard by county. As I said, it defaults to Daugherty, but you can look up any county you want to of the 5 that we have. I'm used to working with a Mac at home, so this gets confusing to me. This happens to be Daugherty County, around 135 indicators. And if you notice the dials, let me tell you about the dials a little bit. The dials are kind of intuitive in a way. The green dial means that you're at least at the 50th percentile or better against the comparison group. Sometimes the comparison group can be against all United States counties. Others, it can be just Georgia counties that it's comparing to, but 50% or above is green. That doesn't necessarily mean that you don't have a problem. Essentially what it means is that you're 50% above everybody else. The caution or the yellow is somewhere between 25 and the 50th percentile. The red or the danger area is less than 25%. So what you can also do if you want to get a quick look at how well you're doing and want to be able to rank them by category or subcategory, one of the things that you can do is just where it says where it says search indicators, order by, you can order it not necessarily by topic, but you can also order it by status, and it'll go from red to green. So this will show you by subtopic, by topic of all those that in Dougherty County are considered a danger area, those that are considered not greater than 50% in the green area. And then there's some that are kind of bluish, you notice. Those mean that there's no value attached to them in terms of either being good or bad. There's the economic indicators, education, whatnot. There's a host of things that you can take a look at. Let's take a look at just one. We've talked about, let's see. Well, actually, we talked about STDs quite a bit, and that is one of our priorities. Let's see where we can, or let's take a look at babies with very low birth weight. This has been a fairly big problem in our community. It's probably somewhere between almost 16%, I think, of all births in Dougherty County are either low birth weight or very low birth weight, which has considerable consequences down the road. But if you take a look at babies with very low birth weight, 2.9%. Of which, if you take a look at on the left-hand side and you take a look at the legend, it says that we are in the red, that we're in a danger area, and there's a lot of room for improvement. If you take a look on the right-hand side, you're going to see that there's some indicators associated with it. Those indicators can either be things that are what would be called risk factors or additional information. For example, these are babies with low birth weight, preterm births. All of those are kind of associated together. As well as mothers who smoke during pregnancy and children living in poverty. All of those are kind of factors which center on low birth weight or risk factors. If you want to, you can view every county. This shows you all the counties in regards to that one single indicator. You notice that Dougherty and Terrell County are in the red, and you notice the rest are either yellowish or well, they're all, the rest of them are yellowish. I think what's interesting, if you take a look at percent of very low birth weight babies and take a look at Lee County at 3.7%, that's kind of like, that doesn't make sense. For example, I think their household median income is above Georgia's. They're around 47,000, which is seemingly fairly healthy, but then yet, in terms of low birth weight, there's an issue there. You know, what we could do is, well, let's click and see what it is. It's still thinking, sorry. Okay. Okay, we got Lee County, and let's see if there's some health disparities. Let's look. Babies with very low birth weight by maternal race and ethnicity. Among Black or African American, 8.7. Among white, 2.3. And overall, it's 3.7, which will kind of give you at least an idea in regards to by group or by gender where we need to take a look at. Also, what we can do, also on this particular site here is, for example, well, what can we do about it? Okay? On the right, you see that there's promising practices. And these promising practices will give you some activities or some programs that have been proven to work. Now, promising practices, they're vetted three different ways. They're good. The way they have it tiered is that they're good ideas, there are promising practices, and then there are evidence-based practices. A good idea means that there's maybe been an evaluation done, but it has not had a control or intervention group, but the results seem promising. A promising practice means that there was a control group, there was a treatment group, and although there wasn't a significant difference, it was seen as promising. The third one means there was a control group, and there was an intervention group, and there was significant difference between the two groups. So if you really if you're looking for a grant, you may really want to go towards the evidence-based, and this will give you a mountain of information in terms of where to go, what to look for. Quite a few of them are in CDC. I think a couple of them Emory mentioned. So if you drill down, you'll be able to see it. Also, there's some questions regarding, at least among some of the researchers, that this doesn't give us maybe all the information we need. I don't think that this particular snapshot is going to give you everything you need, but I think what it can do, though, is it does provide you with some links to drill down a little bit more if you want to. So, what's kind of cool is you can just simply go to the URL of the data. You can click. It's going to take you to the site where the data was drilled down from in the first place. And for example, we want to look at low birth weight. We can click right here. Maybe we want all ages, and we can pick the counties we want. So we can do Georgia, or we also can pick a health district. So it'll summarize data for you. So let's just do, let's do a health district. Let's do, where's Southwest? Let's do Albany. I think that's like 14 counties. What we can do is first let's do white, and I've learned this recently. We do need, if you just want whites only, you do white, non-Hispanic. And then you go get data, and this will be 2011, and this shows you all the data. Should show you a summary at the end as well. It gives you county summary data as well. So, and you can compare years if you want to, 3 or 4 years, you can do that as well. It's all up to you. But you kind of have to know how to work OASIS. And I use OASIS quite frequently, so it's kind of easy for me. So, Southwest Georgia, low birth weight was 8.6%. Let's take a look, and let's do it, that's for white. Let's look at black or African American. And let's go non-Hispanic. We'll go get data. And voila, there it is. And then it gives you a county-wide summary as well. And what you can do, you can export this to Excel, you can run pivot tables if you want to. So it's really fairly functional. All right, so let's see if this works. No, just want to cancel this one. Yeah, I need to go back to the dashboard. Oh, there it is. Thank you. Okay. Also, you can build reports. You can build comparison reports if you want to look at certain things. Let's take a look at, let's go back to the dashboard. Pardon me? That could be, that's probably considered as by age. I think some of the categories do break it down by age, but can OASIS break it down by age? Is that what you're asking, or this dashboard? OASIS can. You can break it down by age. If you want to look at 65 plus, you can find that. If you want to look at 15 to 44 females, you can do that as well. Dashboard, no, not unless it's already pre-programmed. I haven't specifically looked at seniors.
So what does it indicate for the seniors? Are there any?
Well, let's see. They may be some. Let's see if there's some indicators first. Well, I guess we're blank. There we go. Okay, that's Lee County. Let me go to Doherty first. Probably doesn't matter, but. Well, let's take a look. Let's look at prostate cancer incidence rate, since essentially prostate cancer is old guy's disease. Let's see if it breaks it down by age. By race and ethnicity, let's see. I don't see it. Okay, one of the things that you may be interested in doing is building a report. Let's get to that real quick. Pardon me?
At the age of just death.
Yeah, it does. Yeah. Say if you want to create an indicator comparison report. What we can do is type in, or just click all counties. And say we just type in, let's say, cancer. All you got to do now is just populate the chosen content, and it will generate a report for all counties. So I'm just going to select all, just to make it easier. Title indicator comparison report sounds good to me. You have to have a title or it won't run it. If you so choose, you can do an email address and it'll email it directly to you, which is kind of cool. There you go. These are all age-adjusted death rates. If you see a county not listed there, it's probably because there's not enough incidents for them to actually run statistical analysis on it. So let's just look at something that I know that the Cancer Coalition is working on fairly closely. It's colorectal cancer. Let's just pick. That doesn't matter. Let's pick Mitchell. Seemingly, they have a high death rate, adjusted death rate. Actually, that's not even. There's no disparity data there. There must not be enough cases. So maybe that was actually a bad county to look at. Okay, let's go to Daugherty. And once again, you see we have a list of indicators on the right-hand side: colorectal cancer, age-adjusted death rate due to lung cancer, etc. Also promising practices. It breaks it down by gender in this case, but here again, not by age. And then it's got overall by ethnicity. For example, blacks or African Americans are almost twice as likely to die from colorectal cancer than whites are, a huge disparity. And I do know, obviously, that District Public Health is very concerned about that, as well as AAPHC and as well as Phoebe's. And we're very concerned about that and are trying to do some things to rectify it. I know one thing that the Cancer Coalition is doing that's kind of interesting is they have navigators that actually go into the homes, do all the paperwork, and make sure the prep is all done. And their rate of successful colonoscopies based on prep rate is like 98%, which is unheard of. And we're talking about people who are basically poor, who otherwise would not have a screening done. Also, there's some more research, and I may not be exactly right, so somebody can correct me if I'm wrong. But there's a lot of these mail that you get mail at like for a fecal screening, and I heard that those, as far as a screening tool, are very, very good, and that their reliability is almost as good as a colonoscopy. Not quite as good, but here again, it's cheap, and it's a way to get it to a whole bunch of people. If you notice that this is also listed as a best practice. I think it is. There it is. Direct mailing of fecal occult, considered a best practice, and it's also evidence-based, which is a twofer. Also, you'll notice here's the list of promising practices. If you want to go directly to promising practices, you can do that as well. Let me do that. And this is going to list all the promising practices that HCI has in its database. So it's great if you're working on a research project, particularly if you're looking for funding. You might as well fund something that's evidence-based if you can. And so this will kind of give you a heads up on where to look. You can sort by any way you want to. You can sort by keyword. There we go. Can't see it from here. Okay. So maybe I want to go low birth weight, because this is one of our major initiatives. I want to sort by relevance. Hit search. And what you see pop up, for example, is the Centering Pregnancy program. It's an evidence-based program. We actually have a centering program here in Albany. There's also another one, I think it's an Hispanic centering program that's in somewhere near Moultrie. And preliminary data, research-wise, has shown that the centering programs, that the women who go through centering, birth outcomes are as good or better than white moms. So centering apparently works, and Dr. Grant wants to do some additional research to assure that the people that's actually going through the centering program where there's a lot of success, she just wants to make sure that the sampling is fair and making sure that she's not cherry picking in terms of having a biased sample. So we're gonna be delving into that hopefully within the next year or so and help her with the research. You know, we were talking about low birth weight and very low birth weight babies, and this is a map that is called a hotspot map. And on the left-hand side, you'll see a 5-county view. What we did is we took a look at low birth weight plus very low birth weight over a 3-year period, and we plotted them on a map. And what you can notice that this almost looks like Doppler radar. So on the left-hand side, this is like the 5-county view. The right-hand side is more at the zip code level, so it's kind of zoning in on where that hot spot is. And I think I tried to count them, and there was like 178 or 212 or something like that of low birth weight to very low birth weight babies in that hot spot, only that red spot. And if you take a look at where that red spot's located, it's located, Albany State University is part of that hot spot. Another part of that hot spot is South Albany Clinic, run by AAPHC. Another resource is Marion Worthy, that's in that red hot spot. Just north of the hot spot in the yellow happens to be where Phoebe's located. And of course, where Phoebe's located, there's a lot of OBGYN doctors there. So there's a lot of resources there. So you would think, and also the Daugherty County Health Department is it's not in the red, but it's in the yellow, almost into the red. So there's a lot of resources there. So what we're trying to figure out is, with all the resources there, why are we having so many mothers giving birth to low and very low birth weight babies? Well, what we've decided to do is that we want to do some qualitative research first. We're going to do a series of focus groups, and what we want to do is talk with these women and see what can we do to help. So you know, obviously there's something not working. Now, I spoke with one person. She kind of had an interesting take on this, and she said from her experience and from the focus group she's done on similar topics, she's found that women who give birth to maybe their second or third child, it's not their first rodeo, they know the ropes, and they really don't think they need prenatal care. Or they go very late if something goes wrong, I suppose. But what we really want to do is we want to hone in. And with this data that we have, we can actually do some statistical analysis to see if we're making a difference or not. So we're going to be working with Dr. Rosenbaum at Albany State University in crafting some focus group questions, try to get a moderator who has experience in focus groups, hopefully, to do this, and get some results out and kind of figure out as a first step, what can we do? I mean, clearly this is unacceptable. I think there's like, over a 3-year period of time, in our 5-county area, there was like 1,300 or so low birth weight and very low birth weight babies. That's just not acceptable, and we need to change that around. So that's one thing that we're going to be doing, but that's all I have to do.
Good morning. Can you all hear me okay? Yes, okay. Well, my name is Michelle Ritter. I actually graduated from Albany State University almost 10 years ago with my nurse practitioner degree, so I'm an alumni. And I met a colleague of mine, or a classmate, who now also works here, so I'm very glad and honored to be back. Doing the presentation, sorry. Okay. But like I said earlier, I'm a family nurse practitioner, graduated with my master's degree from here, and then I received my doctoral degree from the Medical College of Georgia. I've previously worked in the public health system and also in cardiology. Today I'm going to be sharing a presentation with you all based on a pilot project that I conducted, and it's entitled Enhancing Healthcare Providers' Emergency Contraception Knowledge and Communication with Hispanic Women. So the focus is going to be on the Hispanic population. The main focus of the presentation is going to be on the literature review that was conducted to get the problem statement of my project. The original presentation that I had was about 40 minutes long, and I didn't want to bore you all with theory and a lot of statistical data, so I'm going to highlight some of that towards the end of the presentation. The objectives for today and the topics that we're going to discuss are going to include comparing the Hispanic pregnancy rates at the national, Georgia, and the local levels. We're going to be reviewing factors that contribute to unintended Hispanic pregnancy rates. We're going to be exploring why emergency contraception is a vital option for Hispanic women desiring to deter pregnancy. We're going to identify healthcare provider roles and some barriers to emergency contraception education in Hispanic women. And then I'm going to end by summarizing some of the key project findings and implications for practice. So what ignited my interest in Hispanic pregnancies and birth control? Well, as a family nurse practitioner in the public health system in South Georgia, I noticed that a lot of my Hispanic patients in the clinic had limited awareness about emergency contraception. Most of the Hispanic women would come in for some refills on a pill or for their Depo-Provera shot, and they were already late for the shot or had already run out of pills prior to being seen. So I would start counseling them about emergency contraception. Excuse me. And I noticed that from clinical practice that a big portion of the Hispanic women I counseled had no awareness about emergency contraception. And keeping in mind the Healthy People 2020 goal of improving pregnancy planning and spacing and preventing unintended pregnancies, I began to look at the national Hispanic pregnancy rates and to compare these rates to the Hispanic pregnancy rates in my area. The first set of data I looked at in comparing these pregnancy rates were the Hispanic, non-Hispanic white, and non-Hispanic black pregnancy rates per thousand at the Georgia level, the national level, and the district levels. And I used OASIS, which you've heard a lot of the presenters talking about the OASIS system. It's a wonderful system for you to be able to pull relevant data, so keep that in mind. And then for the purpose of this presentation, if you look on the PowerPoint, I added the Southwest Health District, and that includes counties in the local area. And the counties that I included in that in the Southwest Health District include Baker, Calhoun, Colquitt, Decatur, Dougherty, Early Grady, Lee, Miller, Mitchell, Seminole, Terrell, Thomas, and Worth. So it's a big portion of the counties. If you recall from the earlier presentation, you could actually pull data from a specific county if you wanted to. Okay, but I included the whole Southwest Health District. Additionally, I have the South Health District, and this is my area where I work in. And these counties include Ben Hill, Berrien, Brooks, Cook, Eccles, Irwin, Lanier, Lowndes, Tift, and Turner. So these are a lot of the surrounding counties to this area. So what we can see from the diagram is that on the national level, the Hispanic pregnancy rates are double the rate of non-Hispanic whites and higher than non-Hispanic blacks. The trend is similar if we look at the Hispanic pregnancy rates in Georgia, where they're almost double the white and black pregnancy rates. And then if we break it down further and we look at the county levels, you'll notice that in both the Southwest Health District and the South Health District, the Hispanic pregnancy rate is around 50% higher than the rate for non-Hispanic white women, and between 35 and 40% greater than the non-Hispanic black rates. So in essence, the Hispanic pregnancy rates at the national, the Georgia, the Southwest Health District, and the South Health District levels is significantly greater than the other ethnicities. And the prior presentation talked about the adolescent pregnancy rate. So from analyzing the data that I was gathering, not only did I see that there was an increase in the overall Hispanic pregnancy rate, but also there was an increase in the Hispanic adolescent pregnancy rate. From this diagram, we see that the national adolescent Hispanic pregnancy rate is higher than the non-Black Hispanic rate and triple the rate of non-Hispanic whites. The trend is similar in Georgia, the Southwest Health District, and the South Health District, with the Hispanic adolescent rates being triple the rate of non-Hispanic whites and higher than the non-Hispanic Black rate. So the data that I collected comparing the Hispanic pregnancy rates to other ethnicities really only told me about the rate of pregnancies. It didn't tell me anything about intentions. Were these women trying to get pregnant or were they not trying to get pregnant? It just gave me levels or data. Okay. So what I did is I started researching the literature on this topic, and what I found was that amidst the high pregnancy rates, the majority of pregnancies in Hispanic women and Hispanic adolescents are unintentional. In fact, Hispanic women have been identified in research studies and in the National Survey of Family and Growth as the ethnic subgroups with the highest unintended pregnancy rates. They're 3 times more likely to have an unintended pregnancy than non-Hispanic white women, and only 25% of Hispanic pregnancies are planned, which leaves about 75% as unplanned. So why do Hispanic women in the U.S. have such high rates of unintended pregnancies? Well, additionally, a review of literature that was conducted revealed that factors contributing to the increased rate of unintended Hispanic pregnancies include limited contraception use, contraception discontinuation, high contraceptive failure rates, limited contraception knowledge, and cultural restraints. So the first factor contributing to the high rates of unintended Hispanic pregnancies is limited use of contraception. Research studies that were pulled showed that women in states similar to Georgia had reported limited use of contraception when compared to other ethnicities. In addition, among the women who did report contraceptive use, more than half of them used less effective non-hormonal contraceptive methods such as condoms, even though they were not trying to become pregnant. Another factor contributing to the unintended pregnancies in Hispanic women in the U.S. is contraceptive discontinuation. Compared to other ethnicities, contraceptive discontinuation rates are high among Hispanic women and increase with longer use. So even the women who would start on birth control or on the shot, after a certain period of time, they would come off of it. They weren't consistent with contraceptive use. Contraceptive failure also attributes to unintended Hispanic pregnancies, and Hispanic women are 25% more likely to become pregnant from contraceptive failure and 86% more likely to become pregnant from condom failure than non-Hispanic women. And then lastly, I did another big review of literature and to show factors that were contributing, why these women, why did they have such high contraceptive failures, and why did they stop contraception? Why didn't they continue? And some of these factors that were identified in that review of literature stated that limited contraception knowledge among Hispanic women, incorrect and inconsistent use of the contraceptions that they were on, limited Spanish language education materials, and decreased access to birth control methods, that all these factors impeded continuation of birth control among the Hispanic women who were using birth control methods. So because Hispanic women and adolescents have high rates of non-use or inconsistent contraceptive use, because they have high rates of contraceptive failure, and because they're more likely to use non-hormonal contraceptive methods such as condoms, emergency contraception is an option that can be a critical component in decreasing the rate of unintended Hispanic pregnancies in the U.S. As noted by the U.S. FDA since 1997, emergency contraception is safe and effective. It can prevent up to 50% of all unintended pregnancies and 60 to 70% of abortions. It can be used after unprotected intercourse or after contraceptive failure. There is less chance of incorrect or inconsistent use with emergency contraception because it is used only after unprotected intercourse or contraceptive failure, and also because it can be given as a single dose. And it's available without medical prescription over the counter for women ages 17 years and older. However, similar to what I was coming across in clinical practice, research also supported that emergency contraception use and awareness among Hispanic women in the U.S. is scarce. So they're not really using, or they're not even aware of what emergency contraception is. In fact, only 12% of Hispanic women in states similar to Georgia had ever reported using emergency contraception. Furthermore, only 22% of Hispanic women reported emergency contraception awareness, compared to 72% of English-speaking Caucasian and African American women. So what can be done to increase emergency contraception use in Hispanic women? Well, evidence from the review of literature found that emergency contraception use in Hispanic women could be enhanced by increasing the Hispanic woman's knowledge about emergency contraception, including educating them on correct use and on side effects of emergency contraception, decreasing cultural restraints through the provision of Spanish language emergency contraception education materials, and increasing their access to emergency contraception. And as noted earlier, in addressing this latter barrier, emergency contraception is now available over the counter to women ages 17 years and older. So how do healthcare providers fit into the equation? Well, healthcare providers play a vital role in reducing the rate of unintended Hispanic pregnancies in the U.S. by educating Hispanic clients about emergency contraception. They provide emergency contraception counseling as part of routine healthcare visits. They provide emergency contraception counseling as an option in case of contraceptive failure or unprotected intercourse. And they provide patients with emergency contraception education materials to enhance knowledge and use. However, studies have shown that healthcare providers scarcely use or discuss emergency contraception in practice, and this in turn negatively impacts patient education and use. Another review of literature on healthcare provider barriers to offering emergency contraception counseling for Hispanic women identified several themes. The first theme identified was that healthcare providers themselves had knowledge deficits in emergency contraception efficacy, mechanism of action, time frame, and side effects. The second theme was that healthcare provider attitudes impacted emergency contraception counseling and education. The third theme was that healthcare provider perceptions of colleagues' approval or disapproval of emergency contraception education impacted patient counseling and education. And the fourth was that lack of Spanish emergency contraception education materials impacted patient use and counseling. So additionally, there's a lot of review of literatures in here. Another review of literature suggested that addressing these barriers affecting the healthcare provider's ability to educate clients should include increasing the healthcare provider's knowledge themselves about emergency contraception through in-service trainings, enhancing the healthcare provider's attitudes about emergency contraception through education interventions, and providing healthcare providers with emergency contraception materials to disperse to patients. So all of these three things would help decrease these barriers and help to increase healthcare providers' education for Hispanic women on or about emergency contraception. So kind of to recap what was identified in all of these different types of review of literatures, the key points were that emergency contraception use among Hispanic women increases with awareness and education, that providing Spanish language education material increases the likelihood of emergency contraception use in Hispanic women, that healthcare provider knowledge and attitudes can impact emergency contraception education and use in Hispanic women, and that healthcare providers who participate in education sessions are more likely to counsel women about emergency contraception. So all of these review of literatures that I conducted kind of led up to my project purpose, And the purpose of my project was to increase healthcare provider knowledge and communication of emergency contraception with Hispanic women in a family planning clinic through an education session on evidence-based protocols. So what I did as part of my project was to provide a 1-hour education session to all of the healthcare, or majority of the healthcare providers at a local health department. And the education session was held during a time where the clinic had evening hours and minimal patient care, and this was done in order to minimize disruption to the normal clinic procedures. The education intervention consisted of a pre- and post-test completion and collection. I did a PowerPoint to the healthcare providers on the public health emergency contraception protocols. And then I distributed a Spanish brochure that was actually a part or a component of the emergency contraception protocols that they already had. They just weren't aware that they had this information. And then we did a discussion, or ended a discussion with a session for questions. And then I collected the data from the pre and post test, and they were analyzed using statistical methods. And a rough estimate of the Spanish brochures was conducted at 4 weeks to see if the healthcare providers did actually disperse the education brochure to the Hispanic clients in their care. And this is kind of a sample of the objective slide that I used in my presentation, the actual presentation I did for the healthcare providers. Similar to what I did today, we started off talking about the pregnancy rates. I wanted them to know that yes, this is a problem, especially with the Hispanic population, and that, you know, at our district level, that the Hispanic pregnancy rate was the highest among the other ethnicities. So I wanted them to understand that. Then I discussed the reasons for them of unintended, you know, why is there such a high rate of unintended Hispanic pregnancies, and kind of like I did with you guys earlier, we discussed those reasons. We discussed the healthcare provider's role in deterring unintended pregnancy rates, and then as part of my PowerPoint, I actually reviewed the protocols as stated earlier, and this included talking to them about the efficacy, the mechanism of action, the pharmacology, you know, efficacy being how well does it work? You know, what's the mechanism of action? How does the birth control pill work? A lot of people have misconception that it's an abortive pill, and it's not. So there were a lot of misconceptions that we addressed. Up until a few years ago, the time frame for the emergency contraception pill changed. It used to be that you had 3 days after unprotected or underprotected intercourse to use the pill. Well, that changed to 5 days. That's a significant difference between 3 and 5 days. And a lot of the health providers that I was doing the presentation for didn't realize that. So that was a big eye-opener for a lot of us at the setting. And then we talked about the pharmacological regimen, what types of pills can be used as emergency contraception. It's not only Plan B, but there are other types of pills that healthcare providers can use. A lot of times, some of the pills that the patients even have at home that they're using for regular birth control pills can also be used as emergency contraception. And in these cases, these would be your patients who forget to take a pill. You know, your Hispanic patients that they forgot for a week to take their pill. They couldn't find transportation to get them up to the clinic to get a refill, so they've been unprotected for a while. So it was just, you know, talking to the healthcare providers about, you know, well, they're on this certain type of pill, they can use that as well, not only for regular birth control, but for emergency contraception as well. So there's a lot of education that went on during the session. And then we reviewed the 1-888 Not Too Late brochure. And like I stated earlier, this was a brochure that came straight out of their protocols, of the nursing protocols. And at the very end, there's a little number that says Hispanic patients can call that. However, this information was not being relayed or portrayed. The healthcare provider was not giving this to the Hispanic person. And the reason I like this brochure was because it just gave a number, and it said call this number for emergency contraception information. A lot of the patients that we see have low readability levels. So this was actually a number where they could call and they could speak to someone. So it wasn't they had to actually read any material, but they could talk one-on-one to a Spanish information specialist on emergency contraception. And because of the limited time frame that we have, I'm just going to highlight some of the findings from the project. You know, once I analyzed the pre and post test data, these were some of the findings that I noticed in the small population that I did the project on. The data did support that healthcare providers in the education intervention did lack knowledge. And they specifically lack knowledge about treatment initiation, which was what I stated about earlier, whether it's 3 or 5 days, how long do they have to use emergency contraception. They stated, they lacked knowledge about the pharmacologic regimen, about emergency contraception side effects, and about the mechanism of action. These knowledge gaps have significant implications. First of all, women who come into the clinic that want to use emergency contraception may not be given the correct information. The healthcare provider may not be relaying the correct information to them, which can impact their use. So this is very significant finding. Also, the healthcare providers in the study, prior to the study or the education intervention, they had significantly positive emergency contraception attitudes, slightly significantly. And they had positive intentions to educate women. So they wanted to educate these Hispanic women. They had positive intentions. And the other thing that the project found was that the healthcare providers did disperse the brochures to the Hispanic clients when they came in. And it wasn't a very significant finding, and it was a rough distribution. So, it was kind of hard to say, well, did you give it to the Hispanic patient, or was it for their friend, or who picked up the actual brochure. But the positive thing about it was that it was being dispersed and it was being given out. So implications for practice. Once again, healthcare providers play a key role in decreasing unintended Hispanic pregnancies in the U.S. They have an important role of educating Hispanic women about emergency contraception as an option in deterring unintended pregnancies. However, in order to be effective educators, healthcare providers themselves must be knowledgeable. They need to have positive attitudes about emergency contraception, and they need to have education materials, especially for Hispanic patients. It needs to be Spanish-driven education materials to give to these patients. Healthcare providers can participate in training programs to increase emergency contraception knowledge. Education materials for healthcare providers could be made available via education in-services, through continuing education sessions, through online training, or via the intranet. Periodic refreshers could be offered to healthcare providers, especially those that are directly involved in family planning services. Healthcare providers could participate in emergency contraception group forums to clarify values and distinguish between professional responsibilities and personal values. And they should be provided with Spanish language emergency contraception education materials. Additionally, Spanish language emergency contraception education materials could also be placed in patient waiting rooms so that patients have easy access to these materials if wanted. All right, and that concludes my project. Like I said, I didn't get a lot into the nitty-gritty data and statistical evaluations. I do have all the information if anybody wants to ask about that. Do I have any questions from anyone?
Good morning. I'm Dr. Lanier. I am from Darton State College. I'm actually Albany State alumni. I received my bachelor's degree and my master's degree in education from here probably about 15 years ago. I think I'm the only one that graduated when I was 5. Today I went on and I got my PhD from Georgia State University in Atlanta, Georgia. So today I want to talk to you a little bit about something that touched me personally. As an African American woman being born and raised in Southwest Georgia, I often would hear on different news reports and read in different journals and what have you that African American women have a higher rate of HIV and AIDS. And I thought to myself, well, it's got to be more than the fact that we are African American. And so I decided to delve a little bit into that. So today I want to talk to you a little bit about African American women, gender beliefs, peer perception, relationship power, and sexual behavior. Now, it is true, HIV in 2010 in this nation accounted for about, it was the 13th leading cause of death for all of African Americans. Now, we make up about 12% of the population, but we account for about 47% of all HIV and AIDS cases. In 2010, it was the fourth leading cause of death for African American women 30 to 44 years of age, and the seventh leading cause of death for African American women 20 to 24 years of age. What does this mean? Well, 1 in every 32 African American women will be diagnosed with HIV in her lifetime. And how does this come about? Well, in 87% of the diagnosed cases, heterosexual contact with an infected male partner has been identified as the means of transmission. So we do know that consistent condom use is the most effective way of preventing HIV and AIDS. That we do know. But research has always shown us that, African American women do not use condoms consistently. And I thought, well, I need to understand the behavior of the African American woman in order to determine what we can do to prevent such statistics. And to do this, I used the theory of planned behavior, which is a very reliable and valid theory. It has been used numerous times to examine and understand and predict behavior among men and women. And this theory is based on 5 major concepts: attitude, subjective norm, perceived behavior control, intention, and the actual behavior itself. So in regards to this study, attitude I considered, and let me go back just a minute. The theory of planned behavior is also based on beliefs. So it's not something that's tangible, it's what we believe, and that's how it guides our behavior. So as far as attitude, I use that as gender ratio imbalance beliefs. You know, you hear it all the time. That's the belief that, there's not enough African American men, so we share them, things like that. Gender role beliefs, that the African American woman has to be in a certain place. She has to adhere to certain roles and do certain things. And as far as subjective norm, I use peer perception. You know, how do we feel other African American women think we should believe about condom use? What do my friends think, my girlfriends, other African American women? And perceived behavior control, this is actually the amount of control we have in our relationships. And I define that as relationship power. So what did I know prior to going into this study? Well, literature has shown that as far as gender ratio imbalance beliefs, some of what you hear is actually true. There is a gender ratio imbalance among African American men and women. There's 91.4 African American men for every 100 African American women. This is the highest among all ethnicity, all races. And gender role beliefs, well, it has been shown that gender role is an influential concept in the prevention of risky sexual behavior. Peer perception, well, it's been shown that if our friends think we should use condoms, then more than likely we're going to use condoms. And condom use is greater if the peers state, you should use a condom. Relationship power has been evaluated numerous times among many studies. And just to sum it up for you, those women who use condoms consistently usually feel they have more power or control in their relationships. But now in doing this literature review, I did find that there are some gaps in literature, and that's what I wanted to look at, okay? There has been no collective evaluation of all of these variables together. Peer perception has been evaluated primarily in adolescents, and I wanted to look at the adult woman, the adult African American woman, because of the statistics. That's who's being infected. There's been inconsistencies among past research regarding the role of relationship power. Some studies have shown that it's more influential towards African American. Other studies have said, no, it's no more influential than it is among any other races. And relationship power had not been investigated as a mediator among gender beliefs and risky sexual behavior. And lastly, gender ratio imbalance beliefs and gender ratio imbalance belief influence behaviors had not been quantified. So I did develop an instrument to measure this variable. So the purpose of this study was to investigate the relationship among African American women's gender beliefs. I was specifically looking at the gender ratio imbalance beliefs, their gender role beliefs. I looked at their peer perception, their perceived behavior control, which is relationship power, and their sexual behavior, specifically condom use. I used a quantitative, prospective, correlational study design. I used a sample population of 95 African American women, and they were all administered a set of confidential questionnaires regarding the study's variables. Recruitment took place in the Southwest Georgia metropolitan city. I actually did my research here in Albany, which has a population of approximately 76,000. I used a local historical university. It was done here at Albany State University. I used a local two-year state college, Darton College, and I also used the Dougherty County Health Department, which is a district health department and includes multiple counties. Now, to be included in the study, you have to be a U.S. citizen, first of all, African American lineage, female, 18 years or older, sexually active with sexual activity taking place, heterosexual activity taking place within the last 60 days, capable of speaking and reading the English language, and you had to be single. You were excluded if you were married, homosexual, bisexual, pregnant, trying to become pregnant, or in a long-term monogamous relationship. I wanted the woman who was just simply having sex. So there were several questions that I chose to look at. The first one, and I'm just gonna kind of sum it up for you, but I wanted to know if gender role beliefs were associated with lower perceived relationship power. In other words, the belief that I'm supposed to be a woman and do certain things, does that influence the amount of power I have in my relationship? And I found there was a positive correlation. So those African American women who held stronger feminist belief actually reported higher levels of relationship power. I investigated our stronger gender ratio imbalance beliefs associated with lower perceived relationship power. There was a negative correlation. So those African American women who held stronger gender ratio imbalance beliefs reported less relationship power. What does this mean? If you believe that there's a shortage of African American men and that you have to share your man, then you did have less power in that relationship. I wanted to know, was relationship power associated with an avoidance of risky sexual behavior? There was a positive correlation. Those African American women who held higher levels of power were more likely to practice sexual behavior, safe sexual behaviors. So if I felt I had the power, then I demonstrated it. I used condoms. I looked at our stronger gender ratio imbalance beliefs associated with a decrease in the avoidance of risky sexual behavior. And there was a negative correlation. Those African American women who held stronger gender ratio imbalance beliefs were less likely to practice safe sex. I wanted to know if gender role beliefs were associated with lower risky sexual behavior. And unfortunately, I guess I shouldn't say unfortunately, it's good to know because we now know where to go from here. There was no statistically significant correlation between these two variables. So what it says is that those African American women who have the intention to practice safe sex, it was not associated with her, what she felt her belief as a role as an African American woman. I wanted to know if greater peer perceptions of safe sexual behaviors with partners was associated with safer sexual behaviors. And there was a positive correlation, and you can see that this linear correlation was actually pretty strong. And it showed that those African American women who reported safer sexual behavior also perceived that their peers encouraged them or supported the use of those condoms. Our stronger gender ratio imbalance beliefs associated with an increase in gender ratio imbalance beliefs in sexual behaviors. There was no statistically significant association among these two variables. So gender ratio imbalance beliefs, the fact that there is a imbalance between African American men and women, it didn't influence the African American woman's behaviors. I also wanted to look at the relationship of all of these variables collectively together. So I took and looked at the combination of them all, and I wanted to see how they related to sexual behavior. And I did find that there was, as far as relationship power and peer perception of sexual behavior, it accounted for 31% of the variance for sexual behavior. So what does that mean? That means those African American women with a strong sense of relationship power and a strong support for the use of safe sexual behaviors were more likely to practice safe sexual behaviors and more likely to use condoms. Again, I wanted to look at the collective association as it related to the condom use behavior of the African American woman. And collectively, relationship power, peer perception, all of these variables did not account for a significant part. So although they all account for what we believe, they didn't control the actual condom use itself. Then I wanted to know, lastly, does relationship power mediate the relationship between gender ratio imbalance beliefs and gender role beliefs? And it did not, which was really a surprise to me because that was my initial goal. I did feel that it was our belief system, particularly that there are fewer men and the fact that we're told from small children that we should behave in a certain manner, that would influence it. However, it did not. What the study did tell me is that it provided support that those African American women with a strong sense of relationship power and strong peer support, they are likely to practice safe sexual behaviors. And then collectively, all of the study variables, again, they didn't predict the condom use. But I will say that the collective intersection of the key variables did influence the African Americans' sexual behavior as I initially proposed. So where do we go from here? Well, I think that studies should now start to evaluate and look at the fact of the different sexual orientations among African American women. What do I mean by that? Well, this study specifically looked at heterosexual women because heterosexual contact accounted for 87% of the infections. So in this study, unfortunately, bisexual, homosexual African American women were excluded, and their voices have not been heard. So I do think that's something we should go back and take a look at. Educational levels. I did notice as well as I was doing the study that a number of the African American women did not understand certain sexual terminology, such as heterosexual, homosexual, bisexual, anal, oral, things of that nature. I would like to do further testing of my instrument, the grid behaviors. It has revealed that it's valid and reliable, but I want to go further and use it in more research and do more to just validate it. Further exploration of the association between gender beliefs and relationship power. I do know that relationship power in this study has demonstrated itself as being a strong force in the African American woman's decision of whether or not to use condoms, so we should go back and take a look at that. Any questions?
I've learned a lot this morning, and I'm really looking forward to this. I'm very excited about this project. My name is Michelle Blankenship. I'm an instructor at Valdosta State University, and I'm the project coordinator for the Partnership for Health Project Link. It's a grant from HRSA. We always dedicate our projects to Dr. Jean Temple. She was the inspiration for this project. She started it. Unfortunately, she passed due to breast cancer in 2011. So we always want to, and this is my favorite picture of her. Employee-based health insurance is the prevailing model of health care in the United States. The population is usually covered by health insurance from employers. There's been a very I can't use this one. Is this one working? This one working? There we go. Can you hear me now? Nope. Ah, there we go. Ah, that's much better. Okay. Let me get to the right spot in my notes now. One more. There we go. United States has always had health insurance. Well, maybe I'm going to have to use this one after all. I'm going to do my best, okay, y'all? This one doesn't want to stay going. Technical difficulties. Yeah, there we go. Is that better? Is that better? I kind of tend to move around, so I'll try to stay in the mic, okay, y'all? There we go. Okay. As everyone knows, health insurance is how people get health care. And for people who don't have health insurance, there's a big problem with being able to get health care. Typically, doctors won't take patients who don't have health care. And people who are in lower income jobs can't afford health care, so they're caught in the middle. And that's where we come in. 50.7 million Americans in the United States in 2010 were uninsured. This number is totally unacceptable. And in Lowndes County, 22,000 people were without health insurance in 2010. And I know this is an old number, but it's the latest number that I could find. And of that, 8,700 are living below the 138% of the poverty level. This is important, so just a minute. Uninsured patients account for approximately 20 million ER visits per year. Your typical ER patient is going to be male. He's going to be younger, between the ages of 18 and 44, and he's going to be African American. And generally, they're going to present with a lower acuity complaints. And why is that? Because they can't go to the doctor. This is their form of being able to get health care. These ER patients generally have fewer blood tests done, they have fewer diagnostic tests, and they have a higher incidence of having no tests at all as compared with the population that has insurance that presents to the emergency room. Another interesting fact that I learned when I was researching this is generally the people who don't have insurance, when they come to the emergency room, they're coming for more simple complaints like skin complaints, or they may be having mental illnesses that they can't get treatment for, so they wind up in the emergency room. Whereas people who have insurance generally are coming for cardiovascular or respiratory issues. A significant number of those individuals don't have access to health care. Over 25,000 preventable ER visits occurred in Lowndes County in 2008. And this is from the Georgia Health Equities Initiative. That's a very interesting report. If you haven't had time to read that, that is a very interesting report. The clinic that I work at, originally they thought, oh, we're gonna get this little clinic together, and they told me about this because I wasn't there when this happened. We're gonna get this little clinic together, and we're gonna help take care of all these little issues, like when you got a flu, or when they get stubbed their toe, or something simple, and it's not gonna be anything really big. It's just gonna be a little tiny clinic. Well, in reality, we take care of patients who are sick. They can't get health care. We are able to provide them with their primary health care for chronic conditions. We can get referrals to them most of the time free of charge, if not at reduced rates, to secondary providers for surgeries, and to help take care of their complex medical needs that we've learned that they have. So, Dr. Huft came in on this too, but Dr. Temple and Dr. Maria White wrote the grant for the HRSA grant for the nursing education in 2009. It offered us $1.5 million over 5 years in order to take care of these patients. It is a collaboration between Valdosta State University College of Nursing and the Lowndes County Partnership for Health. Now, Lowndes County Partnership for Health is more than just the clinic. They offer services such as they have a farm that they grow vegetables on, and they offer some workplace initiatives and some other things that I really don't know all of the details of. But it's a very large cooperation in order to help take care of patients in Lowndes County. So the clinic provides health care and a primary health care for the working uninsured. That was the goal of the clinic, and that's what we do. We have 5 nurse practitioners now that are paid by the grant as far as they get release time from the college to work there. And we have 1 nurse practitioner right now that the grant is paying to be there 1 day a week. And we have 1 physician that is getting paid to be there. The rest of our providers are volunteers. They're physicians and nurse practitioners and physician assistants who volunteer their time at the clinic, and they come and see patients free of charge, and they help us to be able to take care of our patients. I work there as a nurse in a support role to help provide education and different things that they need. The goals of the grant were to implement the evidence-based health protocols based on the unique needs of this population, reduce the emergency room use for non-emergent health care among the uninsured of South Georgia, increase exponential learning for the BSN and MSN students. We have students that come through. We have nurse practitioner students that come through, and we have our RN and our MSN students who come through and rotate through the clinic to help provide care for the patients. And all of my students, every time they go, they're like, "Oh man, I didn't even know that place existed." That is a great service that we're offering our community. And we wanted to expand the healthcare services to the uninsured from 2 to 5 days a week. And we actually see patients 4 days a week. And on Fridays, we kind of give the staff who work there a little bit of a break. They see patients half a day on Fridays. We wanted to offer advanced cultural care competencies. And we also wanted to get our students to learn about cultural competencies, and this is a great place for them to learn how to deal with people of different cultures and different backgrounds that they may not be aware of exist in this country. And to evaluate and report the impact of primary health care services offered to this diverse population, and that's why I'm here. The clinic is staffed with volunteers and paid staff that is supported by the grant. We have 2 administrative personnel, a nurse manager and a clinical supervisor, which are paid, and there's how VSU is reimbursed for their time. We provide primary health care services through nurse practitioners, physicians, physician's assistants, and RNs. We offer health promotion and health education services. We do health screenings. We have people from exercise physiology that offers physical exercise routines and helps with weight management. We have a social worker who comes to the clinic. We have social worker students who is stationed at the clinic to help our patients deal with some of the problems that they have. And we also can offer family therapy through the Family Works at VSU. So we wanted to find out how we were doing. So we said, well, we'll providing health care services to the uninsured of Lowndes County decrease their use of the emergency room for non-emergent health care. So we have 1,303 patients right now as of last month. Of those, 58% are African American, 38% are Caucasian, 3% are Hispanic, and 1% is either Asian or other, that they didn't wish to disclose their nationality. We see patients with hypertension, diabetes, cardiovascular disease, asthma, renal disease, any diagnosis that you would see in a normal clinic anywhere in this country, we see those patients as well. We also offer services to help patients get their medications. We work diligently to try to get them their medications on the $4 list at Walmart or Publix or Winn-Dixie or whoever's got a special or a program that's going on, we know about it, and we try to help our patients find out about those programs, because if we don't tell them, they're not going to be able to find out on their own most of the time. So we had 179 patients in our sample. Of those, 330, the year before they came to our clinic, 330 visits to the emergency room for non-emergent situations. I'm sorry. Total ER visits was 330. 129 of those were of a triage level 4 or 5, which is a lower acuity. Within 1 year of being in our clinic, that number decreased to 75. That's a 70-something% decrease. And the decrease in the level 4, level 5 was to 25, which is an 80% decrease. So we are awesome. Our program works. So we have reduced the ER visits. We offer expansive services through multidisciplinary teams. We are growing our referrals. We have physicians who will see their patients in their office. They don't necessarily want to come to our office, but they will see some of our patients and provide them free care in their office. We have surgeons. We have plastic surgeons. We're working on the dermatologist. We have a new dermatologist in town, and we're working on her to try to get her to see some of our patients. We have a collaboration with what we call MedBank, and you know the little things you see on TV. AstraZeneca may be able to help. Well, we fill out all of that. Have you ever seen that paperwork? That is a massive amount of paperwork that patients have to fill out in order to get that service from the insurance, from those drug rep companies. So we fill out those paperwork for them. We tell them this is what we need. We get copies of their W-2s or whatever we need in order to satisfy the company that they are of the lower than the 200% of the poverty line, and we get their medicines for them from those companies for free. And we do that, and that is a free service that we offer at this time. And we have changed in the number of days they've missed work. I have patients that come in and they'll say, oh, Ms. Blankenship, I haven't missed any days work this month. And I'm like, oh, good. They're like, yeah, my paycheck looks so much better since I hadn't had to go to the emergency room and sit there all day. And I'll ask them, we always ask them when they come in, have you been to the emergency room? Have you been in the hospital? Or have you missed any days work since your last visit? And they're like, I don't want to go back to that emergency room. As soon as they figure out that, hey, I can get service better, cheaper, and they actually care about me at that place, we have a very high success rate. And the reason that we've been able to decrease the number of ER visits, and this is my presumptions, is we've offered consistent and quality care to our patients through our providers. We try to keep the patients with the same provider. Sometimes that's a little difficult to do because some of the providers only come once a month. Sometimes they come once every 3 months, but we try our best to keep them with the same provider so that they can build that relationship that you get in primary care. We offer the collaboration with the community providers. We also refer patients to behavioral health services through the Lowndes County Health Department. And the students, they have a remarkable experience, like I said. They just love going to the clinic. They're like, oh, Ms. Blankenship, can we go to the clinic? Can I make up my day at the clinic? And I try to accommodate them as much as possible. We do allow them, they do have so many hours of community service, and a lot of them do most of their hours of community service at the clinic. And our patients just love us. They love that we care about them, and we do. We care about them. We care about their family, and it's just like a big family there. We're the biggest card. We're keeping Hallmark in business because we send cards for everything. Our patients always are getting cards from us, And it's just to let them know that we care about them and that we want them to succeed. And that, it's like the lady said this morning, if you believe it, you do it. And that's all of my presentation. Any questions?